I was looking for a video, kind of a first-person account of alcohol use disorder, and after kind of looking, kind of doing some curation for a little while, not really finding anything I like, I thought I'd do something a little bit different for you guys. So, as I was working on this, I recalled a passage from the book, a detailed biography of Robin Williams. I know we've listened to him before in the class. So let me read you, again, just to give you kind of something a little bit different in terms of methods of learning. Let me read you just a very small excerpt about the time when he relapsed to alcohol after being sober for a number of years. So he writes about being on location in Alaska for a movie. Not really, forget which one it is. Not one of his bigger ones. But anyway, here's from the biography. Having nothing but time and empty space to contemplate, Robin retreated into an unhealthy obsession with his own resume, revisiting loss after loss, tallying up failure after failure, convincing himself that this time he was done for good. My film career is not going too well, he later recalled. One day I walked into a store and saw a little bottle of Jack Daniels, and that voice, I call it the lower power, goes, "Hey, just a taste, just one." I drank it, and there was a brief moment of, "Oh, I'm okay." The instant he took that first sip, he said, "You feel warm and kind of wonderful. And then the next thing you know, it's a problem and you're isolated." Within a week, Robin said, I was buying so many bottles that I sounded like a wind chime walking down the street. So, anyway, I thought that maybe that would be kind of a different way to kind of convey a first person account from a video. So, I hope you enjoyed that. So, one of the things to keep in mind as we go through the criteria for each individual use disorder is that we've already kind of laid out the foundational stuff. Again, much like the section on bipolar and the section on schizophrenia, now that we've kind of walked through the basic criteria for use disorder, you'll see that this is that the definition of use disorder, the criteria for use disorder within each class of drugs has a lot of similarities. So, so let's walk through each one, starting with alcohol. All right, so in criteria A, it reads a primary pattern of alcohol use, clinically significant impairment, manifested by two of the following here within a 12-month period. Okay, so things that we're familiar with from use disorder: larger and larger amounts, or alcohol. Sorry, let me restate. Alcohol is taken in larger amounts over a longer period than was intended. Right, so that idea of oh, I'm only going to have N amount, and then it almost always, if not every single time, is more and over a longer period than was originally intended before the first drink. Persistent desire and unsuccessful efforts to cut down or control, okay, to even decrease use. A great deal of time, and these are their words, a great deal of time, and my words, an increasingly great deal of time, increasing amount of time involved in obtaining, using, and recovering. All right, cravings or other strong desire. So not necessarily a physiological craving, but a psychological desire to use alcohol. You say, well, are those somewhat overlapping? Well, yes, to me they certainly are. Okay, I think here they talk about some of the physiological craving versus the psychological craving. It's not stated explicitly, but that's what I infer from what they were trying to get at here. And then recurrent use. And so recurrent use resulting in a decreasing ability to fulfill a person's primary social roles, whether that's at work, school, home, or some combination thereof. So sorry, I didn't clarify this in the last audio clip prior to this one. So this criteria A, this at least two of the following within a 12-month period is actually a list of 12. So I got the first 5 here on this slide, and then the other 7 are on the next slide. But this is a single list. So again, we're seeing pretty much what we saw in the general use disorder um, criteria laid against the alcohol in specific. So continue despite consequences of all types. Um, Increasing isolation, as we heard mentioned in the Rob Williams biography, that isolation, even when you are a person of you know, probably struggles to find time alone and not have people actively seeking him out. Um, he even then still struggles as finds himself isolated by his use. Um, Increasingly in recurrent use in situations that are hazardous, finding an increased amount of frequency and maybe more intensity in unsafe situations. Okay, and alcohol use continue despite the knowledge of having it of the problem, physiological and psychological problem it's creating, and social problem, right? The social consequences. Knowing all that, but continuing to use despite. All right, and then tolerance and withdrawal. So these are I think I said 12 before, I apologize. So these are the 11, the list of 11 things for the criteria of alcohol use disorder. The guidance from the authors is that you should find two of these, at least two, although often I will tell you you'll find many, and sometimes you'll find all of the above um, from this list over a 12-month period. So I do think these specifiers can be useful to you here. What they do for us here is they offer some guidance around what do we consider um, early remission and what do we consider, using their terms here, sustained remission. So what is kind of short-term recovery and what is extended or long-term recovery, if we use different words. So they define it very simply as early remission is denoted by 3 months of sobriety, but less than 12. So at least 3, but less than 12 months. And then what they call sustained remission or long-term recovery. So I think this controlled environment specifier is also helpful because some people may, although for most of us, the idea of being even being able to access a traditional 30-day or 28-day inpatient rehab program, and i.e. a controlled environment, even that for most of us, if not, for many of us, if not most of us, that's relatively inaccessible, very hard to get uh, authorized in most circumstances. And then even fewer people have the kind of resources to be in an extended inpatient setting or controlled environment, if you will, for weeks and weeks and months sometimes. But it is useful to know in terms of assessing where someone's at, if they've been sober for a month, but they've been in a controlled environment, maybe a few months. Sometimes people are able, and I've certainly, when I was working in health plans, tried to advocate for people to have a phased approach of some inpatient, perhaps detox, depending on the medical detox, depending on the circumstance of the use. Some time in rehab and an inpatient in a kind of 24-hour controlled setting, and then extended sober living with daycare, with day program support. So, and the other thing that this is for yourself, this is not denoted in the book, but kind of keep in the back of your mind that there can be a controlled environment, kind of a 24-hour, very locked down controlled environment, as some inpatient rehabs are. And there can be kind of a controlled environment where it's majority of the time, say a sober living with a daily program, that involves treatment and peer support. So, and there can be a lot of variations on that. But anyway, it is useful to know to what extent the person has maintained their sobriety exclusively in a controlled environment. So I think there's a useful data point here that, according to the authors and the data that they have looked over when they were putting together this DSM-5 version, is that on average it is approximately between 4 and 12 hours after the cessation of alcohol, or even, and they actually point out reduction of intake, that withdrawal symptoms can set in. So, and that, of course, that window between 4 and 12 hours can vary on, was there, in terms of, was there an abrupt stop of use? Was there a tapering down? But either way, they advise that their data suggested it's this kind of 4 to 12 hour window that withdrawal symptoms will set in. And of course, many of the classes of drugs, in kind of, these are my words, not the book's, advanced stages of addiction, meaning that the use has been heavy and regular for a very long time. That, like sometimes with heroin, you may come across clients or patients who say, "I don't get intoxicated. I haven't felt experience feeling quote unquote drunk in many years. But if I don't drink, if I don't initiate drinking right away when I wake up, um, that I will experience, that person will experience withdrawal symptoms." So you can read this, and this is pretty straightforward here on the associated features. But I did want to point out this kind of broader topic that isn't always talked about enough in when we're doing substance use disorder training from a social work or behavioral health perspective. Is that, and I'm also stopping to point this out because this is true of all our classes of drugs in one fashion or another, is that sustained, prolonged use over time has tremendous physiological effects, and causes, in the case of alcohol, causes tremendous physiological damage over time. And this is something we talk about a bit in my integrated behavioral health policy course, in terms of programs and funding programs from a policy perspective that address the physiology of recovery as well as the psychology of recovery. Specifically, getting people having a nutrition be a part of their recovery plan, because most people have been using alcohol, and frankly, this is relatively true for just about every class of drug where there's been sustained and prolonged use. There's just a tremendous amount of malnutrition. And for alcohol, one of the reasons is that alcohol literally burns up everything from the top of your esophagus down through the lower GI tract over time. So really has a lot of devastating physiological effects, as well as um, cognitive deficits of all kinds, including memory impairment after long-term use, and particularly as people age and they've been using for quite some time. Just a couple data points here. The first one, this drinking in low doses, not by themselves, actually make a diagnosis of alcohol use disorder. Alcohol can be particularly tricky because it is a legal drug, and a one that has a pretty wide, berth of social acceptability to it, and in some circumstances, some social circles, uh, relatively heavy use can be very, quite socially acceptable. So, so that can make it a challenge for you in terms of making these diagnoses. Although I will tell you that one of the things that's not necessarily delineated in the book terribly clearly, that I see on a somewhat frequent basis, not necessarily every day, but I see a number of times a year, let's say, are folks who have really don't have kind of daily or any kind of significant functional impairment with alcohol, and might only use alcohol a couple times a year, let's say. But when they do, there's no kind of in between, that they drink to extreme intoxication, often with a range of consequences anytime they drink. So there's definitely times where I've given the diagnosis of alcohol use disorder where the person might drink. And the last one I'm thinking of was a once a month drinker. And but when that person drank, it was always to extreme intoxication, and in fact, there was a significant consequence that involved law enforcement and emergency medical services after a single episode of use that brought that person to me. So, um, and their by their alcohol use was relatively infrequent, but when they did, it was never not a problem. If you don't mind the double negative there. Also, just another thing here. Um, Not only are signs and symptoms of alcohol use disorder similar to those, the intoxication can present itself in a very similar way between alcohol and sedative hypnotics and analgesics, um, or benzodiazepines, if you will. The other thing I want to point out there is that again it can be relatively socially acceptable to mix a an Ativan with alcohol or an Ambien with alcohol, particularly as a sleep as a, a method of bringing about sleep. Um, I can't stress to you enough how incredibly dangerous even the smallest amounts of alcohol are when you're mixing it with even taking such a drug like Ativan or Ambien. Even if you're taking it strictly as prescribed, mixing even low amounts of alcohol are potentially fatal. And I feel strongly that I'm not overstating that because these both of these drugs really heavily suppress the central nervous system, and when it is fatal, essentially what happens, and often it's in the context of someone experiencing insomnia, trying to sleep and finding their Ambien not enough because you build tolerance and dependence, and that's why they're not supposed to be written for long-term use, even though they often are. Uh, that someone will start applying a couple drinks with that benzodiazepine to help sleep, and what ends up happening is they suppress their involuntary functions, most notably the respiratory system, and they just die in their sleep because they stop breathing. And even low amounts of alcohol and this class of drug together are, my opinion, not necessarily stated explicitly in the DSM this way, but high risk of death. Okay? Um, and I think this how this affects the personality and behavior is I think you guys are probably more familiar with. And so, in terms of comorbidity, I'd say sure that there's high comorbidity with almost every mental disorder, and frankly, I think trauma disorders. Although, as when we get to it, I'll give you a little speech about trauma really being more of an injury than a disorder. But setting that aside for the moment, of course, there's high comorbidity to me because why? Because people are in pain, and alcohol is the most easily accessible of these classes of drugs, and they bring short-term but very palatable relief. And unfortunately, and we've talked about this, I know in class in the in-person part of our class. Um, but that comes with a great debt on the back end. Short term, very noticeable relief, but once the drug is out of the system, their symptoms generally and their overall feeling, their overall mood, and even physiological feeling is much worse. All right, so criteria for alcohol intoxication. Again, you can certainly, and when you're doing kind of mobile crisis or emergency room type of work, you may often see alcohol intoxication without necessarily finding criteria for a use disorder per se, for sure. So the criteria is pretty straightforward. The nice thing about one of the things that I like that the authors did in this section that in the criteria for intoxication I think in just about every single class of drug, if not all of them, is that the criteria C, and it's usually C, but not always. That won't be a multiple choice question on an exam. But what you'll see within there is a list of particular observable phenomena to denote intoxication. So we say, well, what exactly does alcohol intoxication look like, right? Well, this is a very handy list for yourselves um, to uh, to um, to pay attention to in terms of is to assessing for intoxication. Okay, again, you'll see a very handy, to me anyway, and why I put it in bold, very handy list of what does alcohol withdrawal actually look like. And certainly alcohol withdrawal can be life-threatening. It's not always, but it can be, particularly if a person has a other health history of seizures or other cerebrovascular problems. Okay, so it is at its best, if you will. It is very unpleasant, but it is also potentially fatal and needing of acute care treatment. So just so you know, for the criteria, you would diagnose alcohol withdrawal if you see two or more developing after cessation of the alcohol or even reduction. It can occur kind of this withdrawal syndrome can occur between several hours to a few days after. So there's kind of a wide range in there. And again, I think anecdotally, I would say to you that this depends on have they kind of slowly tapered themselves down, or do they cut themselves off abruptly in terms of when you'll see the onset in this window here. But this is a good list to hang on to. And so uh, for the hallucinations part, um, they actually put that on a specifier. So with perceptual disturbances, one of the reasons why they did, I don't think it's stated explicitly in the book, but what I infer in terms of why they put the specifier in there is that generally, if they are having psychotic symptoms, that they probably need to have a hospital level um, of care for the duration of their detox or withdrawal management. And sometimes, if you're working in an emergency room or other kind of acute intervention setting where you're doing, or you're working in an admissions office where you're responsible for doing the insurance authorization uh, for withdrawal syndrome, for treating withdrawal from alcohol. Um, this is one of the things that most of the insurance companies, or at least when I've dealt with them in the past, if there are perceptual disturbances, and certainly if there are any history, any evidence of current seizure activity, or even a history of seizure activity or the cerebral vascular problems, generally that will meet their medical necessity criteria for inpatient. Generally, I don't want to say that as an absolute, um, but that's why that's there. Um, Most people, according to the data that the authors had, um, that most people, their withdrawal from alcohol is kind of more akin to something very unpleasant, um, and even a particularly nasty hangover can really just be a withdrawal. Um, so but about 10% people need what they call dramatic symptoms, and dramatic symptoms would likely, in almost every circumstance, are going to necessitate really acute care level medical supervision of that withdrawal process. Okay, seizures directly as a direct cause, or as a direct cause and effect from alcohol withdrawal, according to the authors, happens around 3% of the time.